Alright, last one. I think this will be the last one until we take a quick break, a breaky poo, and then Jeff will come in here and lecture or go over y'all's quiz. Okay? Is this working? Come on.
Can we skip the quiz review?
No, that's between you and Jeff. I mean, perhaps. It's pretty quick though. I think the last time it only took like 15 minutes or so. Okay, hyperglycemia and diabetic ketoacidosis. We've all heard of the keto diet. Why do people like the keto diet, although doesn't work well for long-term weight loss? Is because ketosis is when our body burns fat for energy. Okay, we use glycerol and fatty acids that can convert into ATP through a different process. But the byproduct of this ketosis is acid. Okay, and not only that, ketones are acidic themselves, like hydroxybutyrate. Right, it's just acidic in itself. So just be aware of that. So the whole just stopping, thinking of hyperglycemia. Water follows salt. Water also follows glucose. So if someone has a high amount of glucose in their blood, they will end up dumping water, okay? Lots of water. So the hallmark of hyperglycemia, the issue they run into is dehydration. They lose too much water. DKA becomes a problem of dehydration. HHNS becomes a problem of dehydration. So that's something to lay out as a foundation, okay? Now, there's different reasons we can be hyperglycemic, right? Of course, excess food, insufficient insulin, infection, illness, injury, surgery, emotional stress. Now, these right here, what do all of these sound like? Actually, all of these right here. What do you think is released in this scenario? There's a hormone that responds to stress. Say it. Who said it?
Cortisol.
Cortisol. Yeah. Which is a glucocorticoid. What's the equivalent of cortisol that we carry on the ambulance?
Solumedrol.
Solumedrol, prednisone, dexamethasone, all of those, right? It is the fakies of cortisol. It's the fakes, okay? So that's how that happens. Now, again, other causes of hyperglycemia. Your book calls it the Dawn phenomenon and Somogyi effect. Do you know anything about that? Never heard of her. So, what?
So what it is, the Dawn phenomenon, so if you go and you test your nighttime sugar and you say, oh, 130, awesome, great, no problem. So you don't take any medication, you go to sleep, right? Well, your body recognizes at some point, oh, 130, I need to release insulin to keep that down within and control. However, it goes so low, so your body releases sugar so it doesn't have a hypoglycemic effect, and then you wake up in the next morning after not having taken anything, and your sugar's like 200, and you're like, whoa, how did that happen? It was your body making sure that you didn't go into a hypoglycemic coma while you were sleeping as a result of your natural sugar being a little bit elevated at night and you're not taking in meds.
Good to know. I did not know that. All right. Also, patients with type 2 diabetes may go undiagnosed for years. Okay? So just be aware, that's like a very common thing. We talked about that earlier. Pre-diabetes, people don't know it. Okay? Now, something that makes these a lot easier to diagnose on the National Registry is the value of the glucose they give you, and I'm going to explain this in a minute. DKA typically, prototypically, will be 400 or like between 2 and 400. Okay? HHNS, more than 400. In fact, it'll usually read high, HI, because it'll be in 6, 7, 8, 9, 10, 1100. Okay? Very, very high. I'll show what that means here in a minute. But,
I got a question.
Yeah.
So like after somebody eats or stuff in your face with cookies, after you eat all those cookies, I don't know, I guess it depends how much sugar's in it, but what's your sugar typically going to spike to?
You know, it varies. It shouldn't go above 200 ever. Okay?
That was my question.
That's the question. Should not go over 200. If it does, diabetes.
So if you have somebody that just ate a yogurt and their sugar was showing like 398.
Oh, yeah, that's diabetes. Yeah, diabetes for sure. If I were to eat this cookie or eat 10 of these cookies and have a single blood glucose reading of 200 or more, diabetes. Okay? Make sense?
Yeah.
So it should never go above 200. Does it go over 200 in a large portion of the population? Yeah, but it's not supposed to. If it does, diabetes. Okay?
And
Make sense?
Like, okay.
No.
So say, how would you necessarily treat that?
Like type 2 diabetes, so like metformin, Ozempic, Mounjaro, something like that.
On the back of the truck?
Glitazone, what?
On the truck?
Oh, I'm sorry.
Dilute the pollution.
Yeah, someone's glucose of 200 or 300, don't care. It's fine. Now, something you have to consider is the fact they're probably dehydrated if it's 398 like you used an example of. So we treat it with glucose. Or I'm sorry, we treat it with saline.
Just gonna give fluids.
How do you make sweet tea not so sweet?
Dilute it.
You dilute it. So that's one of the ways you can do that. Okay? Now, consequently, they're usually dehydrated anyways, so you give a fluid. Okay? Now, I want to point something out since we're talking about this. Let's say someone comes to your ER or in your ambulance and their blood glucose is 450. Let's just say it's 480. Okay? It's really high. You cannot lower someone's glucose by more than 10 points an hour. So what does that mean if it's 480 and you're trying to get it back down to 120-ish? They're getting admitted. In fact, they're going to the ICU. So, because floor nurses are crazy about doing insulin like that. And not only that, it takes an expert. It takes an expert to lower that and monitor these patients. Because you can have cerebral edema. You can most certainly have electrolyte imbalances. You can be precipitated in DKA, HHMS, something like that. So be aware. It's a very complex procedure to lower someone's glucose. The consequence of lowering it too close is permanent paralysis, right? So central pontine syndrome, we talked about that in neurology. But the bigger consequence is just generalized cerebral edema, okay? So there is huge consequences of lowering someone's blood glucose too quick. Make sense? Yeah? All right. Good, Dylan? Okay. Let's see. Oh, we talked about this. So the blood glucose will have a massive osmotic diuresis. So that water is going to follow the sugar, and they're going to end up peeing it out, especially when it's over 200, their glucose, okay? In fact, diabetics, a lot of times they'll dip their urine, and the dip stick will just test to see if there's any sugar present. If there's sugar present, they know their glucose is about 200-ish. You know, like it could be a little variance in that. So that's one way they'll do that, okay? Another way is, have y'all heard of like ketosis people? They will dip their urine and see if there's protein in their urine. Okay, so they'll test these, and diabetics will do the same thing. So they'll have a dip that tests for several things. The big ones they're looking for is protein and glucose in their urine, because it means there's a derangement. Now, again, ketones themselves are acidic, and how these work causes acid. So the ketones in bloodstream cause a decrease in the blood's pH. What's the normal pH? 7.35 to 7.45. So someone in DKA can have a blood pH of 7.33, and that's DKA. Now, you ever notice how I don't give you a wild number like 7.1 or something like that? It's because people don't live at that. You will die, okay? So realize, I think I would have to look up the number, but if someone gets less than 7.3, the chances of mortality is like above 80%. It's very, very high. Like you're going to die at that point. So just be aware that it's a very narrow window that you can be in and still stay alive, okay? It's not going to be like 7.2, 7.1, something like that. No way. They're going to die, or they're in the process of dying, okay? Now, in type 2 diabetes, I want you to know DKA is rare because insulin is still present. So let's talk about this whole diabetic ketoacidosis thing. How it presents is blurred vision, polyuria, polydipsia, polyphagia, orthostatic syncope. What does that sound like to you, Wes? Orthostatic syncope.
They stand up, they pass out.
Good, yeah, fainting upon standing, okay? Frequent infections and skin ulcerations. Again, they'll have a decreased LOC that's deteriorating gradually. Nausea and vomiting, tachycardia, deep, rapid respirations called Kussmaul respirations. Why is that?
They're trying to
Trying to blow. So, Dylan, is their end title going to be high or low in Kussmaul respiration?
It's gonna be low.
Mm-hmm. It's low. They're blowing off more CO2 than they're making to compensate for a metabolic acidosis. Very good. So remember, hot and dry, they sugar's high. So they're going to have warm, dry skin and dry mucosal membranes. What are the mucosal membranes? It's inside your mouth. So when, just like a puppy and their nose is not wet, you know, you think, oh, they may be dehydrated. But same for a human, right? If their mucosal membrane is bone dry, you think they're dehydrated. So it's something that we might look at. What's another way we can test for dehydration? A clinic, like in the field. Skin turgor. So you take the back of their hand, you pinch it together, and if it stays pitched up like a tent and it slowly goes down, it means dehydration. It could mean dehydration, okay? So be aware of that. Now, fruity odor of ketone on the breath. Have y'all ever heard of this, right? So, in case you don't know, alcohol and acetone can be excreted. So I told you most things are excreted in the urine. Alcohol and acetone are excreted through the lungs, which is weird. They can be excreted through the lungs in a portion. So what happens is acetone, when you breathe it out, it smells fruity. Only about half the population can smell that smell, so your partner may smell it, but you don't. But that's what's happening here. And remember, ketones will break down into acetone, so that's why it has that smell of like fruit. It's like a fruity smell, okay? So that's where that's coming from. So if you're on an exam and they say fruity odor on the breath, it's DKA, period, close the book, it's done, it's DKA. Okay, they're throwing that at you. It's a buzzy word. Now, abdominal pain, hypotension, why would they be hypotensive? Why is, what? They're hypovolemic. Yeah, good. So they're going to be, you know, thin and dehydrated appearance, sunken orbits, right? Their eyes are sunk into their head, you know, warm, dry skin, orthostatic hypotension. And I feel like they say the same shit over and over again, so off we go. Now, the management of this. Insulin therapy is delivered at the hospital. Someone had mentioned they worked for CareFlight and their critical care paramedics carry insulin. Yeah, they do, but that's for a transfer continuum of care, not initiation of care. You don't give insulin in the pre-hospital environment. It just doesn't really happen. So just keep that in mind. So if they're hypotensive, you can administer isotonic fluids. What is isotonic fluids?
Saline.
Yeah, same. 0.9% saline, right? It's what we carry on the ambulance, okay? And you're going to monitor for cardiac arrhythmias. Now, what they're worried about is, it's very strange. It's hyperkalemia because there's increased potassium in the serum, but a general depletion of body potassium. So we know that hyperkalemia presents with peak T waves and flattened P waves. So one way that we can soothe these membranes to avoid an arrhythmia is the administration of y'all's favorite, sodium bicarbonate and calcium chloride or calcium gluconate. So I'll say that again. In cases of hyperkalemia DKA, you can soothe the membranes of the heart by giving sodium bicarbonate and calcium chloride or calcium gluconate. Okay, and these will help stabilize those membranes to hopefully there won't be as much of an arrhythmia. Okay, this is temporary. This just buys you a little bit of time, and hopefully you avoid VTAC or torsades or something to that effect. So that is kind of one of the managements. I will say this is exceptionally rare for for paramedics to do this these days, but there are some systems that will allow it. Okay, I'm pretty sure the FTOs here will do something like that. So this is more an advanced practice thing, but it does happen. Okay. All right, let's break down this word. Hyperosmolar, hyperglycemic, non-ketotic syndrome. What does that sound like? Right? You have this excess osmotic pool because they're high blood sugar, but they're not in ketosis. Okay? And if you see this, that always equals type 2 diabetes. It's always type 2. Okay? So it used to be called HHNK or HONK. I still call it HHNK. That's how I was taught in school. So just be aware, potato, I don't care, pick your poison, but they're the same thing, okay? Now, this is a hallmark of type 2 diabetes, and it's characterized by hyperglycemia, altered mental status, drowsiness, lethargy. It's very similar to the other one, but I'll show you the difference here in just a second. Few patients can be in a comatose state. But the big thing that they will both present with DKA and HHNS is severe dehydration, okay? Now, again, there is a huge overlap between the two. And this will typically, let's bottom up, often develops in patients with diabetes who have a secondary illness that leads to a reduced fluid intake. So could you imagine someone that gets a stomach bug that's, pooping their guts out? They could end up with this could happen. This is how because they have a reduced fluid intake, and then they also have this cortisol dump, which raises their glucose, and there's a lot of pieces to this, but just be aware, okay? I'm not going to read the slides chill on these because it's very repetitive to other ones, but I do want to point out this one. This is worth knowing. The blood glucose levels are substantially higher, much higher. I'm going to show you this slide. You might want to take a picture of this slide. This tells you exactly the bare bones of what you need to know between HHNS and DKA. HHNS will almost always have a blood glucose more than 600. Versus DKA, it's usually 250 to 400, maybe 600, okay? But HHNS is going to be much higher. Why does that happen? Because it's type 2 diabetic, and they will still be producing insulin, so they can go longer. So that gets their blood glucose much higher. That's the difference between the two, okay? Ketone bodies are not present in HHNS. and it's associated with type 2 diabetes. As opposed to DKA, their blood glucose is going to be more than 250, their pH is going to be low, acidosis less than 7.3. Really, I'd say it's less than 7.35 is a better way to word that. Ketone bodies will be present. Ketone bodies are acidic, so it causes metabolic acidosis. And the type of diabetes is type 1 diabetes, okay? So this is the answer. Airway management and normal saline boluses is almost always required for these patients, okay? You have to aggressively rehydrate these patients. This is what will, besides the arrhythmia, this can kill them. They will be that dehydrated. We're talking normal DKA patient, they're gonna get 6 to 8 liters over the next several hours. Like they are that dehydrated, okay? So bag after bag after bag after bag. Are we doing that in the field? No, but the emergency room will be doing that for them, okay? Any questions on whole diabetic pathology? We're going to move into some different stuff. I'm sure you're tired of hearing me talk about diabetes. I don't blame you. Hang with me. I know you are getting tired, so am I. So pancreatitis. I showed y'all where the pancreas is. You can see it on this section of the guts right here. So it kind of starts in the midline and it points towards the spleen, okay? The pancreas, and then this is the way it points, but then it dumps its contents back to the right towards the duodenum. And this is both an endocrine and an exocrine gland, okay? Now, what happens is there's these pathologies, and pancreatitis is self-digestion of the pancreas. So remember that the pancreas can digest carbohydrates and proteins and fat. Well, what do you think the pancreas is made up of? Carbohydrates, proteins, and fat. So if these get out of the glands, it can self-digest itself, and that's what's happening in acute pancreatitis. So let me show you. How does this happen? Well, there's some pathologies that this happens to more commonly than others, but by far the most common one is ethanol, alcohol. So alcoholics get pancreatitis. I'll say it again. Alcoholics get pancreatitis. Alcoholics get pancreatitis. But it can also be idiopathic. Idiopathic means we don't know. Gallstones. Remember I said that the pancreas dumps its contents into the common bile duct, right? And then they'll dump into the duodenum. So what happens is if there's a gallstone stuck in that duct, it can back up the pancreatic fluids and start causing self-digestion of the pancreas, pancreatitis, right? Steroids, I told you about mumps. What does mumps also cause in men? What does mumps also cause?
Prostate cancer.
No. It's orchitis, inflammation of the testicles. Okay, that's okay though. Oddly enough, scorpion stings can cause pancreatitis, and that's really certain drugs like sulfa drugs can cause it as well. But these are just general things that I want you to know. What? I get smashed. Yeah, that's one of the mnemonics from our book, the medical school book, that we can use to remember that. Now, there's acute and chronic pancreatitis, but here's what I want to point out. The pancreas sits in, so it's both exocrine and endocrine. Well, it also sits in the peritoneal and retroperitoneal space. And you can see this in the way the patient bleeds. You can have Colin sign, which is periumbilical bruising, and Gray-Turner sign. You remember Gray-Turner, you got to turn someone over to look at their back. So Gray-Turner sign. So if they tell you patient alcoholic, and he has periumbilical bruising and flank pain bruising, and he has extreme abdominal pain, it's pancreatitis. Okay, they're throwing you they're throwing you a bone. That's what they're telling you. Now I want to point out this is extreme. This is a late stage of a bruise, this is the beginning of a bruise. This is it might be a little more subtle like this. Okay, so just be aware that they're not. This doesn't always happen, but it can happen. Okay. Now, how it will almost always present is they're going to have excruciating abdominal pain, like extremely bad abdominal pain. Imagine an organ digesting itself. It's going to be painful. So it's going to be extremely painful. Tachycardia, nausea, vomiting, and abdominal distension. As you can imagine, when an organ digests itself, it can cause a lot of swelling, okay? Now, the management, it's really pretty easy. It's supportive care, just like everything we've been talking about today. So lifestyle changes are critical for chronic pancreatitis. So if someone drinks every day and they've had 8 rounds of pancreatitis in the last 2 years, they got to stop drinking, or else they're going to end up with chronic pancreatitis, and then they're going to end up as a diabetic. This can lead to diabetes because if you completely trash out the pancreas, you end up with diabetes. All right. Any questions on that? We good? Good, guys? All right. All right, let's talk about adrenal insufficiency. So this is underproduction of cortisol and aldosterone. These are produced in the adrenal glands. Is it in the cortex or the medulla?
Medulla.
No, you had it backwards. It's the cortex. It's the, oh, it even says it up here. Cortex. So it's produced in the adrenal cortex. And why do I keep telling you this? Because they put it on the slide, so it's coming. They're going to ask a question on that. So it results in, basically if someone has adrenal insufficiency, it can cause them to not be able to maintain their blood pressure. So weakness, dehydration. Dehydration comes from the whole water follows salt thing. If they don't have this is out of balance, and they have a difficulty maintaining their blood pressure. Okay. Now, I want to show this. Did you know John F. Kennedy? Of course, John F. Kennedy, JFK. Yeah, he had Addison's disease, and what happens is you can end up with hyperpigmentation of the skin. So you notice that this is a white guy, but his skin is really dark. And if you ever looked at JFK, he almost had like an orange complexion. It's because of Addison's disease. And I'll talk about why that happens. But basically, in Addison's disease, I want you to think you as the paramedic needs to add in some steroids. You need to add in some steroids in Addison's disease because they're not producing enough. And basically, the true full-blown primary Addison's disease is very rare. It's usually idiopathic, meaning we don't know why it happens, but it occurs when 90% of the adrenal cortex has been destroyed. So what does this look like? Hyperpigmentation of the skin. You'll have pigmentation of the oral mucosa. See these black pigmentations? Not supposed to be that way. Okay, this is pigmentation. This is melanin that's spilling over into the gums. Okay, they'll even have pigmentation of the palms, like in this one. So just be aware. If they tell you someone hyperpigmentation, you need to think Addison's disease. Addison's disease, as the paramedic, you need to add in some steroids, okay? Addison's disease. Now, how does it present? Fatigue. What is anorexia, Wes?
Low weight or like wasting weight.
Well, it actually means you don't want to eat,
Okay.
okay? It means you don't want to eat. So anorexia is the medical word for not willing to eat. Salt craving. So if someone's missing mineralocorticoids, which regulates salt management, they may be craving salt. All right, so they may, they may want salt cravings. Muscle joint pain. So again, if they have a dysflow in their electrolytes within their kidneys, the aldosterone system, they could have, low potassium, low sodium. All these things can happen. But the big word that I'll say they tend to give away in Addison's disease is increased pigmentation. Okay? Yeah, here you go. So basically, I don't think you need to know these exact up and down arrows, but the sodium concentration of the blood falls and the potassium can rise. And this has to do, again, with aldosterone. It's annoying, but I would be shocked if they asked you that. That's fairly advanced pathology. Or pathophysiology, okay? Now, again, we know that hydrocortisone is used in the acute management of this crisis, okay? So dexamethasone, prednisone, cortisol, or cortisone. So these are all trying to mimic cortisol, okay? And we also have to try to balance the electrolytes with sodium and potassium. Do we just give straight up potassium to patients?
Depends.
No, straight up, not dripped, but straight up potassium? No, we don't. That's how we kill inmates in the state of Texas. We give them a large dose of potassium. It stops the sodium-potassium pump of the heart. They die, okay? Their heart stops. It's one of the concoctions that they use. So just be aware, if you give potassium, really any element, it's dripped, right? We drip it in. Same thing with magnesium. We tend to drip it in, okay? So this is primary adrenal insufficiency. I want you to think primary adrenal means that the adrenal gland is where the pathology lies. So it's primary and adrenal gland problem, okay? As opposed to, this is annoying, the differentiation between the two, secondary adrenal insufficiency, the problem is not the adrenal glands, it's the pituitary gland, okay? So they could have a pituitary gland tumor or a problem with the hypothalamus. It doesn't really matter which one, but this is secondary adrenal insufficiency. So there's a problem outside of the adrenal glands, secondary, that's causing this insufficiency, okay? This can also happen from a patient that's been taking steroids for years and years and years. So y'all know transplant patients and patients that have autoimmune syndromes like lupus, multiple sclerosis, they take high dose of steroids to knock down their immune system. Remember me telling you, when we have a lot of cortisol, it tells your T cells, we don't want to waste our precious resources on you. You take too many resources, so your T cell level will drop. And we do that on purpose to knock down people's immune system that have autoimmune disorders. So that's one of the ways that we treat those. But all that to be said, if a patient who's been taking steroids for years and years and years, or even weeks, and they suddenly stop, their adrenal glands have kicked off because it's being, why do their adrenal glands need to work when there's an excess amount of glucocorticoids that are sitting in the blood from them taking it by mouth? So that's something to consider. Pretty fairly common that you can run into this problem. Good. So we talked about Addison's disease. When it's just like someone suddenly stops taking corticosteroids, it's called an Addisonian crisis. Okay, very similar. But again, Addison means you need to add some in. So the chief manifestation is shock. You need to know that cortisol plays a really important role in alpha-1 upregulation. So basically, we know all our blood vessels have these alpha-1 receptors. They don't exist without cortisol. So if someone doesn't have cortisol, the alpha-1 levels will drop. So it doesn't matter how much epinephrine, phenylephrine is floating around in the blood. The blood vessels won't be able to grab that. It won't be able to bind to a receptor to do its job. So one of the problems that happen when we don't have enough cortisol is we have downregulation of alpha-1 receptors, and that's not a good thing. So cortisol will upregulate alpha-1. So as you can imagine, if your blood vessels are not able to squeeze down because the receptors have been downregulated, you're going to end up with low blood pressure, right? You could have confusion and weakness as a consequence, okay? Severe pain or vomiting, okay? Yeah, look for arrhythmias, okay? Now, Cushing syndrome, this right here, these aren't, as they like to call them on the Reddit, sick-ass lightning tattoos. These are stretch marks. And this is a hallmark of Addison's disease. They will have truncal obesity, so they're really fat in their abdominal and trunk region, but not really anywhere else. And they will have what's called moon facies. See how, and this is medical terminology, not me picking on this lady, but like see how her face is round like the moon? That's the words they will use. Moon facies, truncal obesity, okay? What is Cushing syndrome? It's too much cortisol or too much corticosteroid hormones. Have y'all ever seen someone where they're trying to immune suppress them and they look like this? They have that really fat round face, right? You probably didn't realize what you're looking at. That's how that happens, okay? It's because we're trying to give them a bunch of cortisol and glucocorticoids to knock down their immune system so they don't reject their kidney transplant, or so their lupus doesn't fire back up, or their multiple sclerosis doesn't get as bad, okay? So just be aware. Now, with that, I told y'all cortisol knocks down all the things that we don't need, and it really, when we're under stress, we just want to survive. So it will raise your blood glucose levels, but protein synthesis is impaired. Again, to synthesize protein, it takes a lot of resources, and we don't want to waste them. So we don't when there's cortisol risen. So that doesn't. So we end up with muscle wasting, and the bones will become weaker. There's a whole long story on that, but I guess you could know that this will cause osteoporosis, which is softening, thinning of the bone. Okay, so if someone takes steroids for a long period of time, they will have thinning of the bone. It's a known thing. All right. Let's see. As you can imagine, someone taking a lot of prednisone for a long period of time, they could have weakness and fatigue, increased thirst and urination, high blood glucose because it's a glucocorticoid, weight gain. I told you they'll have huge abdominal weight gain, like strictly in their abdomen, which is strange, like just fat in their abdomen, and thinning and darkening of the skin, even the areolas, which is weird, okay? So like you'll hear that in medical school, and of the lips, like their lips and their areolas will get darker, okay? Of course, it's supportive care. That's what we do, supportive care. Manage the ABCs, it's generally supportive, okay? This next one, I've never seen this. I don't know if Robin's ever seen it, but it's called a pheochromocytoma, and this is annoying, but it's basically a tumor of the adrenal gland, specifically in the medulla. So what's in the medulla are catecholamines. So if you have a tumor in the catecholamine portion of the adrenal gland, you'll have paroxysmal release of norepinephrine and epinephrine. So what would happen if your body randomly just released a bunch of norepinephrine and epinephrine? Matt, what do you think is going to happen? If your body just randomly decides to release a bunch of norepinephrine and epinephrine, how are you going to feel?
Races.
You're going to have palpitations, anxiety, tachycardia, hypertension. How does this classically present? 38-year-old female, she's reporting of episodes of tachycardia and hypertension. You put her on the monitor, she has a heart rate of 210 and a blood pressure of 280 over 200, right? That's what would happen if someone got a bunch of norepinephrine and epinephrine, and then 20 minutes later, vital signs are normal. That's a pheochromocytoma, okay? Pretty rare, but here we are in paramedic school talking about it, okay? But that's a pheochromocytoma. Plus, if you say pheochromocytoma, you're sounding sophisticated. So just be aware of what this is, because like I said, not just because it's rare does not mean it's not rare. That does not mean that it is rarely tested. Now, y'all know like Andre the Giant and gigantism. We'll talk about the difference really quick because it's on your PowerPoint. But we have this thing called growth factor, right? IGF-1, right? Insulin-like growth factor 1. And basically, if we get a tumor on the hypothalamus or the pituitary gland that says release this hormone, as a kid, if we get that tumor, it causes gigantism. As an adult, if we get this tumor, it causes acromegaly. And I want you to notice this lady. She has acromegaly. She started off pretty normal looking female, and then she has a tumor of her pituitary gland that increases the amount of growth factor, human growth factor, or growth hormone. And see how she has like more of a manly, round or a coarse face, and even more of a coarse face. This is what happens with this, because the bones have already ossified, so they can't really get taller, but their bones will get thicker, and it creates this appearance. And see how like her hands, like they just look thicker and bigger? That's what happens in acromegaly, okay? So it's oversecretion of growth hormone, okay? If it's undersecreted, of course, then they're gonna be small. But that gigantism, it's when this happens pre-puberty. Or before, yeah, we'll call it pre-puberty, or before the growth plates ossify, okay? We're almost done, guys. Hang with me, and then we're going to take a little break, and then we'll review the quiz. Hypothyroidism versus hyperthyroidism. So someone, without looking at this, how do you think a hypothyroidism patient will present, Dylan? Hypothyroidism. How do you think that'll present? Help them out, someone.
Weight gain?
What?
What's hypo?
Weight gain. What is hypo? It's low, right? So weight gain, lethargic, fatigue, sleepiness. Okay. Now, what do you think hyperthyroidism will present as? Agitation, hyper, like they're like physically hyper, right? Tachycardia, heat intolerance, weight loss without trying to lose weight. So what does that sound like? Doesn't that sound like a good time, right? You lose a lot of weight, you have a lot of energy, you don't need to sleep. What does that sound like? It sounds like a potential for abuse. So just know it's a thing that women, teenagers and women are abusing levothyroxine. For that reason, don't recommend it. But it's happening, so just be generally aware. So yeah, these are listed up here if you want, but they kind of make sense. Think hypo, low, hyper, high. Makes sense, okay? Now, occasionally they'll ask you about something called Graves' disease. Have you all ever heard of exophthalmos, right? So notice how this lady's eyes are bugging out, kind of like Roger Rabbit, you know, the movie. See how they're bugging out? What's happening is the thyroid hormone will increase the amount of these things called GAGs, glycoaminoglycans, and these hold a lot of water. So this stuff in the back of your eye is building because the thyroid hormone is in excess, and it starts pushing your eyes out, not by choice. It's not like they're just looking startled at you, but this is Graves' disease, okay? And it's the most common cause of hyperthyroidism, of course. This is an autoimmune condition, oddly enough, where you basically have this immunoglobulin that looks like TSH. But you could also have a visible neck mass called goiter. And I want to show y'all what goiter looks like really quickly, because this is a word that they throw around occasionally on exams and it scares students. So goiter is swelling of the thyroid gland, and it's usually painless. But Can you appreciate how these people's thyroid glands are swollen? That is goiter. Do you also want to notice if our, right, third world country probably? So again, they lack iodine, and that's probably why it's swollen. So let me tell you, if someone lacks iodine, a lot of times they will get goiter. Goiter is swelling of the thyroid gland, okay? So, Graves' disease, hyperthyroidism. Something they're probably going to throw out to you on that is that they have bulging of the eyes. They may also say their eyes look like they are startled, right? To where they're like startled like that. Those are words they could use, okay? Now, do y'all know anybody that has Hashimoto's thyroiditis, right? No? This is actually super common right now. Basically, what happens is, again, the immune system will directly attack the thyroid. And so when you attack the thyroid, it quits working and you end up with hypothyroidism, okay? Now, I know it says it can cause hyperthyroidism, but it's transient. It's only for like a month or two. So eventually, I want you to think Hashimoto equals hypothyroidism, okay? And basically what happens is the immune system gets confused and it attacks the thyroid itself. And when it attacks it, it kills those cells, and then they end up dying. And then you end up without thyroid hormone. So you end up with hypothyroidism, okay? Now, this last one is called myxedema coma. And basically, this is the most extreme form of hypothyroidism. And this is like extremely lethal. But what is the swollen neck here called? Matt, what is this called? Wes, what is this called?
Goiter?
Goiter. Yeah, good. This is goiter. Now, this will present with mucinous material in the skin. Why are they telling you this? They will straight up give you this on an exam, and you need to be thinking, oh, this is myxedema, okay? Myxedema literally means, they'll describe this as dough-like skin. Has anybody in here ever made fresh dough before and know how that feels? Their skin will feel like that in myxedema coma. Myxedema means that. So keep in mind, this is slowing of the metabolic processes. This is hypothyroidism. They could or could not have goiter, but they probably will tell you they have dough-like skin. That's like a buzzy word that they'll probably throw at you if they want you to pick this, okay? Now, this is another example of a lady. Notice her puffy, swollen eyelids. She's losing her hair, okay? This is hypothyroidism. They will always feel cold because their basal metabolic rate is a lot lower. They will gain weight because their basal metabolic rate is lower. Their skin will be dry and they'll be sleepy, okay? So they could also, I want you to pay attention to her eyes. They might tell you that her eyes are puffy. That's something that happens in this that might kind of push you towards choosing this as an answer, okay? Yeah. It's often precipitated by triggers, and this is hypothyroidism. They will often present with hypothermia. What is hypothermia, Robin?
Low temperature.
Low temperature, yeah, good. The care for this is supportive, as you'd imagine, but they might actually require intubation. I think the lethality on this is 80%. When patients get to this, there's a pretty about 80% chance they're going to die. So it's very high mortality on this. So you might have to intubate them, and passive rewarming for hypothermia. Robin, what do you think passive rewarming is?
Cold environment, not anything that you actively do or apply to them, but just you bring them out of their cold environment into someplace not cold.
Well, good. Now it says avoid sedatives, narcotics, and anesthetics. Why do you think that is, Dalton?
For filtering and they're probably build up.
Well, every metabolic system in the body is slowed, including the ones that break down what we're giving. So you really have to consider this when you're administering a medication to these people. Every metabolic system has been jacked up. Every one of them. So when you give them a lot of narcotic or sedative or something like that, the breakdown of that, the metabolism of that is a lot slower. So the basal metabolic rate is lower, metabolism. So that's something to consider, okay? That's myxedema coma. Any questions? All right. I think it's like one of the last ones before we get to diabetes insipidus. Thyroid toxicosis. So this is actually just excess thyroid hormone. And the causes are, so it kind of makes sense, right? Thyroid has become toxic. So hyperthyroidism, goiters, autoimmune disorders like dequerberian thyroiditis, stuff like that. Thyroid cancers can cause this as well. So just be generally aware that if you have a patient that, you know, they have a big old swollen neck and they're hyperthyroid presenting, you know, heat intolerance, tachycardia, irritability, insomnia, stuff like that, it might be a thyroid toxicosis. Now, what you actually have to worry about these as a paramedic is arrhythmia, like a thyroid storm too. You have to really worry about arrhythmia, like tachycardia, SVT converting to VTAC or VFib or an RNT phenomenon, something to that effect. So just be aware, as I keep saying over and over again, it's supportive care. You have, all of these endocrine things can cause arrhythmias, okay? I don't even care about hyperparathyroidism, but let me just quickly ask, what does the parathyroid do? What element did I tell you I'll keep in mind about that? Oh, big L. What does parathyroid hormone do? Dylan? Not enough coffee? It's calcium, guys. The parathyroid hormone manages calcium, relates to the bones.
I knew that.
Yeah, it's calcium. I'm not even gonna talk about that because I don't think you'll need to know about hyperparathyroidism. Now, this one, we'll talk about it real quick. Okay, the word pan means all, okay? So pan-hypopituitarism means all of the pituitary is low, okay? So pan-hypopituitarism means all of the pituitary hormones are low. So that's what they're saying here. Inadequate production of or absence of all pituitary hormones. How this occurs, oddly enough, is a condition called Sheehan syndrome. Basically, when a woman's pregnant, her pituitary gland grows, and if she has blood loss during her pregnancy, she will have a hypoxic insult to her pituitary gland and it will die. So then about a week or two post-pregnancy, if she had lost blood during her pregnancy, her delivery, she'll end up with pan-hypopituitarism, okay? So not super common, but it can happen. It's called Sheehan syndrome, okay? All right, last one. This one's important. I know you are tired, but hang on. This is like, I've been talking about shit that I don't think is important. This is actually really important, okay? We've heard of diabetes mellitus. That relates to blood sugar. There is this thing called diabetes insipidus. If you want to do your FPC thing or CCPC, as you get into your career, they will drill you on this. You got to know it. So diabetes insipidus is when, let me see if I can, we'll zoom in here. No, I won't actually. Diabetes insipidus means diabetes mellitus. Are you peeing a lot? In diabetes, do you pee a lot? Mm-hmm. You do. So diabetes insipidus, like if someone's insipidus, it literally means that there's a lot of it. So they're peeing a lot. Diabetes insipidus, okay? So in diabetes insipidus, you end up lacking antidiuretic hormone. What does antidiuretic hormone do, Dalton?
Keeps you peeing.
It keeps you from peeing, okay? So if you lack the hormone that keeps you from peeing, what are you going to do?
Not pee.
You're going to be peeing a lot. If you're lacking it's called a double negative. So if you're lacking the hormone that keeps you from peeing, you're going to be peeing a lot. That is diabetes insipidus. How does that happen? I'm glad you asked. It's this. Usually in head trauma, they will sever the pituitary stalk. So someone bangs their head in a car wreck, okay? And then 8 hours later, they've peed 8 liters, right? In 3 hours, you need to think diabetes insipidus, okay? Now, the same thing can happen, and it's called SIADH. And this is syndrome of inappropriate antidiuretic hormone. And what this means is they have too much antidiuretic hormone. So if we have too much antidiuretic hormone, that means you have too much of the hormone that's saying don't pee. So what happens is they don't pee. And what happens when they don't pee? They dilute their blood. That's SIADH. Both of these commonly will present after head trauma. It's severance of the pituitary stalk is what they want you to know. Okay?
So they dilute their blood?
They dilute their blood, correct. And they're not peeing in SIDH. The complete opposite of that is diabetes insipidus. They're peeing out. So they become very dehydrated. Make sense? That was the last slide. Here is the comparison chart on that one. I know that was a lot. I don't blame y'all for being tired. I'm tired myself. I hope I didn't just totally rattle your brains on this. But this is the stuff that paramedic students tend to not do well on. And I don't blame you. It's extremely complicated. So, and I'm trying to teach what I learned over 2 years in, a day. So you may have to go back and watch the lectures. I definitely recommend you read your books. If you have questions, reach out. If y'all want, let's take a 10-minute break and then come back in here if you want to do the quiz review. It sounds like some of you need to leave. I understand. But if not, stay in here for the quiz review and Jeff will come do it in the next 10 minutes. Sound good? All right, I do appreciate y'all's time and I know that's a lot. So let's take a 10-minute and I will text Jeff and tell him to come across.